Panel discussion on the management of early stage breast cancer, and we've got a good mix of surgical oncologists, radiation oncologists, and medical oncologists in the panel. And to conduct this panel, we have our good friend Dr. Kaustup Thalapatro, who is the Director of Radiation Oncology at Nanavati Hospital. I would welcome Dr. Kaustup to come on stage and call up the panels, please. Dr. Kaustup.
At the outset, I would like to thank the organizers, especially Prashanjit Da, Shayon, both very close friends, and Apollo for giving me this opportunity. May I now call upon all the panelists, Dr. Sheila Mitro, radiation oncologist and senior consultant, Apollo Multispeciality Hospital. Dr. Jyotirup Goswami, senior consultant at Saroj Gupta Cancer Center and Research Institute. Dr. Anish Bandopadhyay, who is associate professor radiation oncology at NRS. Dr. Anita Ramesh, the senior consultant medical oncology at Apollo Specialty Hospital, Chennai. Dr. Saurabh Sarkar, senior consultant pathologist at Narayana Super Specialty Hospital, Howrah. Dr. Abhishek Gangopadhyay, who is a consultant surgical oncologist at CNCI, Kolkata. Dr. Somnath Pandey, consultant and HOD of nuclear medicine and molecular imaging at Quadra Medical Services. Dr. Suparno Kantipal, who is a radiation oncologist and associate professor of radiation oncology at IPJMER. Dr. Devlina Gangopadhyay, who is a consultant medical oncologist at Apollo Multispeciality Hospital, Kolkata. Dr. Shantam Chakraborty, who is a senior consultant in radiation oncology at Tata Medical Center. Dr. Shubhodip Chakraborty, who is a surgical oncologist and a senior consultant at Apollo Multispeciality Hospital. And Dr. Shuman Malik, who is the radiation oncologist and director of Narayana Super Specialty Hospital, Kolkata. So I think we have a extremely esteemed panel, and I would just request the panelists to stick to time, be very crisp, not to be too elaborative, so that there are a lot of questions. I have made this panel thinking of, I was told by Sayan that there will be a lot of students and young radiation oncologists, so we wanted to cover quite a bit of basics also. So what is operable breast cancer? Anybody, any surgeon, quickly.
So T1, T2 and N0 or N1, but it depends upon the molecular classification also in which you want to operate upfront and you want to go for neoadjuvant.
Right. So before going on to the case, let us have the screening recommendation. What are the guidelines on screening? Anybody, any takers for screening? Quickly.
Routine screening, 40 years and above, where you use the dual screening method with digital as well as ultrasound, physician's examination and breast self-examination. If you have a strong family history, you do 10 years before the index case in your family, or you already have a BRCA positive, the screening guidelines changes. There is conflicting little data whether you screen between 40 and 49, 50 and 59 and little above them. But I think as far as India is concerned, in a resource constraint, it's better that screening continues what is going on now.
So basically various guidelines, various recommendations have slight differences. Like if you go to ESMO, can I have a pointer please? Yeah. If you go to ESMO, they say strictly it's 50 to 69 and may also be done for 40 to 49 and 70 to 74 years, although the benefit is lesser. Having said that, the other guidelines like ACR and US Preventive Task Force Services, they talk of the younger age group as Dr. Anita has talked about. Of course, for BRCA mutation carriers and untested first degree relatives of carriers, screening has to start much before that and usually recommended at 25 to 30 years. MRI for screening. Any radiologist here? We have a radiologist, right? No.
Just common sense, dense breast, family history of cancer, BRCA-ness of the tumor, BRCA positive late female.
Yeah, so this is clearly the NCCN guideline. They talk about individuals with a genetic mutation or a first degree relative of a gene mutation, individuals who receive thoracic RT between the age of 10 to 30 years. Suman, would you, Suman is a, Jyotirup.
Thalapatro, would you use MRI only in selected cases? Because we had a very interesting session by Professor Sarkar, you must have heard it, regarding screening in India. And as Madam has said that we use MRI screening only for those with
Yeah.
genetic mutations, dense breasts, or whether clinical findings don't correlate with the conventional imaging findings.
Yeah, yeah. So only in those situations, MRI screening is still not routinely recommended, and I was just enlisting where you would be, which are the recommendations where you would consider MRI screening. So this is a point which I found interesting, and I thought I would ask one of the radiation oncologists. For individuals who receive thoracic RT, this is NCCN guideline, no?
Yes.
This is who receive thoracic RT between ages 10 to 30 years. Would you recommend MRI screening in that subset of patient? Jyotirup, Suman, anybody?
See, with rampant use of MR screening, we can have false positive, more false positive, and more intervention in the breast. So I think if it's not dense breast, even for irradiated breast, USG or in elderly mammography is good enough. But if there is high suspicion, then we can consider for MR breast.
Yeah, so although NCCN recommends it, I do not think in India we are still practicing this age group. And in India we have, as Suman has rightly said, we have made it more individualistic, and you have to use your common sense and your applications to decide whether for this subset would you use MRI-based screening or not. So now let us come to this case, one simple case to start with, and we will get on to discussions. So we have a 70-year-old post-hysterectomy lady presented with a screen-detected right breast lump. On examination, 3 into 3 centimeter palpable in the lower inner quadrant of left breast, and 1.5 centimeter palpable axillary node, no family history. But mammogram, left breast 2.3 into 1.9 centimeter, right breast NED core biopsy, IDC grade 2, ERPR strongly positive, HER2 new 1, Ki67 is 35%, PET CT there is no evidence of metastatic disease. Radiologist, anybody we have? No radiologist. So may I ask Dr. Devlina Gangopadhyay to talk about the diagnostic workup? Just brief on diagnostic workup.
Okay, so in early breast cancer, unless there is a tumor which is say more than 5 centimeters or lymph node positive, will not recommend investigation to look out for distant metastasis, because the incidence is really low. If it is stage 3, say fixed lymph nodes or the size is more, the burden is more, then maybe a CT chest, abdomen and bone scan, or else PET scan will do.
MRI for diagnosis of breast. So again, we have talked about MRI for diagnosis, and primarily MRI for diagnosis is, since the radiologist is not here, I'm just rushing through this slide, multifocal or multicentric disease, or may be helpful for breast cancer evaluation before and after pre-operative systemic therapy to define the extent and response to the treatment. Coming to our nuclear medicine expert, Dr. Pandey, do you think PET CT in early breast cancer is mandatory? Would you recommend in all, or if at all, where would you recommend?
Sir, as far as early breast cancer is concerned, there is a clear-cut evidence that there is no benefit in doing a PET CT in a stage 1 disease patients. The normal routine investigations suffice. In stage 2A, it is not yet confirmed, work is going on, but it is still is a gray zone is there. After it becomes a stage 2B disease, there is evidence that doing a PET CT.
So I'll ask you a very specific question.
Yes, sir.
High burden of axillary lymph nodes. Would you do a PET CT or not?
Yes, sir, definitely we'll go for PET.
So suspicious of metastatic sites, any painful distant sites, or high burden of axillary nodal high burden of suspicious axillary nodes. These are the 3 areas where you would recommend PET CT.
Right, sir.
Do we agree with this?
Right.
Right. So that is about PET CT. Regarding core biopsy or FNSC, can we ask Dr. Saurabh Sarkar to talk about it?
Biopsy is always preferred over FNSC. Basically, sometimes differentiating that low-grade malignancy from atypical hyperplastic lesion is very difficult on cytology. So we prefer biopsy, and also for detection of immunohistochemistry markers and Ki67 also, we prefer biopsy rather than FNSC.
So Dr. Sarkar, what's the importance of Ki67? Do you assess all samples for Ki67, or there is a subgroup of patients where you would be assessing Ki67?
So basically, it has a significance in prognostication in luminal type of breast cancers. So other than that, it has no use basically for treatment purpose. We are doing this Ki67 mainly for those presenting with high ER receptor and low Ki67.
Yeah, Dr. Anita, one quick comment. Yeah.
So I don't think so nowadays anybody does FNSC anymore for a breast tube.
No, a lot of people are doing it, but it's not recommended.
Not
to do
recommended.
it.
The
I know
trend is
people who-
changing.
yeah,
See, when
practice is changing,
I'm in the medical college, I do get cases still now.
Yeah.
But then we keep on saying, I need a core biopsy. But only indication of FNSC patient very sick, you need an urgent something to do, I think. And Ki67 nowadays happens reflex.
Right.
We are not asking with ER, PR, HER2, and Ki67 comes with the report.
So role of PET-CT we have already discussed. The reason for not asking for a PET-CT in early breast cancer or operable breast cancer is the probability of metastasis is 2% is what most of the literature says. Dr. Santam, do you agree with this?
Yeah, I agree.
Great. Genetic counseling, any takers? Dr. Subodhit? Anybody, Dr. Anita, Dr. Gangopadhyay? Which patient you will be sending for genetic counseling? These slides I have put because I just wanted it to be a refresher for the students.
Generally, when there's family history, or if there's a history of a male breast cancer in the family,
Right.
or there are mother or first degree relative having breast and ovarian cancer, or triple negative breast cancer below the age of 50. So those are what we go for BRCA testing.
Right, correct.
Any
So-
woman below the age of 25, I think in ovary it has been started. Very young woman, you go for this.
So basically, very young age, male breast, diagnosis of TNBC at an earlier age than where it is usually diagnosed. These are the indications for sending or asking a genetic counseling and germline BRCA1, BRCA2 mutations in this subset of patients. Neoadjuvant chemotherapy versus upfront surgery. So Dr. Subodhip, you were there for the case, you saw the case. Would you recommend upfront surgery in this patient?
If
It's a 2.7 centimeter
I
mass.
would like to go for a FNSC of the axillary node.
Okay.
So whether it has a metastatic deposit, if it's node positive, obviously I will.
So even if you have done a core for the primary, you would still be doing an FNSC for the axillary node?
Generally
The
we.
core is there. Core is said it is
if
IDC grade 2.
The axillary node could be infective also, if it's not metastatic. So if we do a FNSC, that confirms, it gives us we go for NSCT upfront. Or otherwise,
Are we routinely doing that after doing a core for the primary?
we
Are we
get-
routinely doing a axillary nodal FNSC?
at times we get patients, we are doing it on a few cases, sir, not all cases. Because if it's a node positive clinically, generally we send for NSCT.
Considering the
also.
age and if the node is mobile, I would like to go for upfront surgery for this patient.
So N1 node, do we need to send all patients for neoadjuvant chemotherapy, and if at all, which patients? Dr. Gangopadhyay.
So if the histology is triple negative or it's a HER2 positive disease, patient is fit enough to tolerate chemotherapy, then neoadjuvant. In this case, 70-year-old lady with strong hormone positive disease, operable breast cancer will go for surgery first.
Yeah, so I think this case poses a better, case or a selection criteria for upfront surgery. Of course, if you had a higher nodal burden in the axilla or HER2 neo positivity, TNBC, those are the situations, as she has rightly mentioned, are the situations where you would consider neoadjuvant chemotherapy. When we have a primary diagnosis from the primary tumor and additional tissue diagnosis from an axillary node is on a judgmental basis, and we cannot say to the audience that should be performed routinely. Of course, based on judgment, a clinician can take a call and perform it. I think that.
Now there is a lot of papers and emerging trend for more role of medical oncology in the early stage breast cancer. Even with the smaller HER2 tumors, you can plan for pertuzumab, trastuzumab based triple negative neoadjuvant. Even some of the IOs have now come up as a neoadjuvant. So people are looking into, even in a smaller tumor, how we can give you the pathological response rate. So I think as far as we are concerned, we have not completely jumped into it, but there is evidence to suggest, yes, we can continue, start with the systemic therapy in a small tumor as well.
So this is, I think this is a sitter breast conservation surgery or mastectomy, so I'll not get into the details. Of course, I think if you have a facility and if a patient is willing, breast conservation surgery is the way to go. What I would ask is, what are the contraindications for breast conservation surgery? You can take it, any of the surgeries.
Obviously, if the mammogram is showing a diffusely appearing microcalcifications, that means a multicentric disease. And also if there is some contraindication to adjuvant radiation in those cases, and also if you're during this surgery, if your persistently margins are positive in frozen section, those are the situation you can avoid the breast. And also obviously the patient's will, you have to explain that radiation is mandatory after breast conservation, and in early stage there may be a possibility, though it's not sure, that after mastectomy there may not be a need of radiation. So this is patient discretions is one of the important factor that we have to give importance.
So I mean, Dr. Shubhadeep can educate us. Actually, most of us are, the non-surgical crowd here, lot of non-surgeons here. What is oncoplasty and the role of oncoplasty in operable breast cancer when you are doing breast conservation surgery?
Yes, first of all, we have to first evaluate the patient who are fit for BCS. The thing is that there are two types of oncoplasty, where basically is type 1 oncoplasty, where we take the local tissue and move out and reconstruct the breasts. And type 2, we take a tissue which is from the other side. It can be from a LD flap, it can be a ALT flap or a thigh flap to reconstruct the breast. The only thing, Aridnam, is that when we compare our studies with the UK and stuff, we see that in UK, whenever they are doing BCS, the contralateral breast, they undergo a mastopexy also. But in India, when we try to say the patient, explain to them that you might require to have the same contour or opposite side surgery, patients do not. So that is the thing.
So breast tumor breast ratio, is that a ratio that you use?
That's the thing. Obviously, that is the thing, and also the position also.
Right. Reconstruction post mastectomy, I think it's a vast topic, and let us forego this, because our radiation oncologists, lot of them are sitting quiet, and I definitely want to have an interaction with them also. And next we will be talking, we will discuss a little bit about radiation, because we have almost 7 people from the radiation oncology who are there on the panel. So prophylactic bilateral mastectomy in which setting? So quickly, any of the surgeons can take it.
If there is a BRCA 1 and 2 is positive and it's patient is willing for it, you have to explain. In Indian scenario, it's little difficult to explain, and if the patient is willing, then you can go ahead.
So management of axilla, Dr. Santam, is radiation equivalent to surgery? You have 2 large trials now, results of 2 large trials. Is radiation equivalent to surgery?
After axillary lymph node dissection?
No, either after axillary lymph node dissection or per primum.
Per primum, right. Per primum in patient who has a clinically node positive disease, data from older trials suggests it is not.
Yeah. So I'll make it easy for you. I'll give you a scenario. Sentinel lymph node done. Micrometastasis in 2 nodes dissected, micrometastasis in 1. And surgeon has not operated forward.
As per IPCSG, you don't need to give them RT.
Right. So this was the question, can RT replace ALND? Anish, do you agree with Santam?
Yes. Even for one single node positive, I will give radiotherapy instead of axillary node.
No, the question is radiotherapy to axilla.
Yeah, radiotherapy axilla.
You will give radiotherapy to axilla, is it?
And the
so can I have a voting from all the who will do one sentinel node positive? Who will do radiotherapy to axilla among all the 6 of you, and who would not do? Santam, Jyotiroop, Anish, Suparno, Sheila, Suman. You would do radiotherapy to axilla?
Yes.
Okay, and you are not concerned about axillary morbidity? Sentinel node. Shantam, do you agree?
I think there's a nuance involved in this question, right?
Yeah.
If this is a 70-year-old ERPR positive 2 centimeter primary with a 1 sentinel lymph node, and you have dissected 3 which are clearly negative.
Not this case, I'm saying any case, 1 out of 2, 2 nodes dissected, 1 positive.
I don't think you can make a judgment like that, because we don't routinely give it yet, because our auxiliary class solution we are still developing. Radiotherapy class solution for auxiliary radiotherapy, we are still developing it. And so we don't
more than
routinely
half
do it.
the panel thinks they should do auxiliary radiation in this setting.
If you ask in US, more than half the panel will agree that you should do
So
auxiliary radiotherapy.
Finally, I have managed to create some controversy. So
Yeah, but the question that remains is that what are you giving and what are you taking?
So can you just elaborate and
Yeah,
sum it
so
up
if
for
you
us?
basically look at the trial which answers this question, it is the Amaros trial,
Right.
which clearly shows that if you give auxiliary radiotherapy after a patient who has a sentinel node positive disease, instead of doing auxiliary lymph node dissection, you do get away with a lower risk of arm lymphedema. It's not insubstantial. It's still there, around 10 to 12% patients still experience arm lymphedema. What they lose is...
But Amaros, the surgeons have always claimed that it was never well powered for recurrences.
That is true for Z11 also. None of the sentinel node trials have been powered for recurrences. Anyway, so what we lose by giving auxiliary radiotherapy vis-a-vis lymph node dissection is more shoulder morbidity. That has been clearly shown in the pro outcomes, which is there unfortunately in the supplement.
Wait, fine. So I think we'll stop it here, this discussion. Move on to the next discussion. So this patient underwent a right BCS with sentinel node biopsy, partial breast reconstruction with a thoracic epigastric flap. These are the reports, 3 out of 17 positive axillary nodes. How would you proceed? Chemo versus no chemo, choice of endocrine therapy, and radiation aspect. Chemo versus no chemo. Do you think this is a patient in whom you will offer something like Oncotype DX? Yeah, positive, strongly positive. That was on the histopathology itself. 888.
She's the same lady.
Same lady. No, same lady. So would you offer Oncotype DX?
No, node positive.
Yeah, so okay. So so coming to the next question, in which cases would you offer Oncotype DX? If it was N1, 1 node positive, would you have offered Oncotype DX?
Oncotype DX has mainly on the node negative disease, T1, T2. But there is also a sub-analysis where they have taken into consideration N1 disease, small tumor to see what's the recurrence risks. So whether we are low, intermediate or high, and wanted to look into whether we can avoid the systemic therapy in this subset of patients.
So Oncotype DX is primarily for node negative patients is a very important message. A very small proportion where you can still use it for 1 node positive, but you should not use for high nodal burden patients, even if they are ERPR positive. That is the message to the audience. What chemotherapy would you use, Dr. Gong? Yeah.
How old is this patient?
How old? She was, I think,
74.
71.
So in a postmenopausal woman with 1 to 3 lymph nodes positive, the RX-Ponder trial, which was a mirror image of the node-negative Taylor-X trial, showed distinctly that if your recurrence score is less than 25, there's no need to give chemotherapy in a postmenopausal woman. So in her 70s, I would really advocate that this woman have Oncotype DX with 1 to 3 positive lymph nodes.
So my next slide is RX-Ponder trial, and this is exactly what Dr. Shahina has been talking about. So postmenopausal women with 1 to 3 nodes positive and RS 0 to 25 can likely safely forego adjuvant chemotherapy. Having said that, in India, still asking for Oncotype DX in 2 nodes positive and 3 nodes positive has still not become the general trend among medical oncologists. I mean, would you agree with that, Dr. Anita? 3 nodes positive.
No, we don't do.
Right.
We don't do it at all.
But these are the results of RX-Ponder trial. And as Dr. Shahina has mentioned, these are the recommendations for postmenopausal, and these are the recommendations for pre-menopausal. Endocrine therapy for pre- and postmenopausal women, of course, I mean, we all know that it is tamoxifen and AI, so we will skip that. And let us get on to radiation questions now, in which, if this patient was 77 years old, would you have omitted radiation? Suporno?
If the thing is, this is a she has a if she was 77 years old, and since she has a three nodes positive, which is N1 disease, I would still consider radiation, but if she was a node negative patient, being ER/PR positive.
Anish, can you just sum it up? Which patient would you omit radiation in this subset?
ER positive, strongly ER positive, node negative, maybe. Yes.
Age?
This age group, which is 77, you're saying.
There was this trial, the PRIME trial, which they did where more than 65, very early stage, less than 3 cm, node negative.
Mike, please.
No LVI, no high risk factors, and hormone receptor positive, HER2 new negative. They did omit whole breast radiation after BCS in a certain subset of these women. But here she is in one.
Anti-HER2 therapy, of course, these are the recommendations. We can go through the recommendations. Role of adjuvant whole breast irradiation after BCS. What fractionation each one uses in this setup? 2.7 centimeter primary, one node in the axilla. One node in the axilla. What is your dose fractionation, Suman?
So for this category, nowadays we are using fast forward for up to N1 for early breast.
Jyotirup, fast forward or moderate hypofractionation?
So for this patient, because she's node positive, I wouldn't be thinking of fast forward actually, because we need to treat the nodes. So that would still be 14, 15.
Which nodes would you treat in this?
So
the
because
supraclav.
she
one
has,
node positive,
yes.
would you? So my next question is, in this setting, one node positive, would you still be treating the supraclavicular?
Yes, I would.
Axilla we have talked, you
Yeah.
would. So all one node positive, do we treat supraclavicular, or we see the yield to dissected ratio and additional features of LVI and PNI, and then take a combined decision on whether to treat supraclav for one node positive out of 14 or one node positive out of 18, if that is a clinical situation? Or do we treat it for all comers? Santam?
Currently, we treat it for all comers.
One node positive, all comers, 1 out of 18, no LVI, no PNI, still you will treat it. All comers.
5 and 16.
Sheila? All comers, okay.
But moderate, not fast forward, moderate.
Moderate. Suporno, moderate or fast forward?
Moderate, 14.
Sheila? Any takers for fast forward here? Shantam?
Not outside the trial.
Is Rima there in the audience? Yes, Rima, your comment please, quick comment.
So at TMH also beyond the pandemic, T1, T2, N0 is where we will be using.
So
preferably
only N0s,
postmenopausal.
no N1, even if it's one node positive, no fast forward.
No fast forward.
Okay.
That is because we just don't have the data to support lymphatic irradiation yet.
So choice of fractionation we have talked about, and 40 grain 15 fraction is your choice of fractionation? Or is anyone using your Canadian NCI fractionation 42.5? Is anyone using? Anish is using 42.5, okay. So, in whom should we consider fast forward ideally? Left-sided breast cancer, medial quadrant, otherwise all your features are fitting well. Medial, lower inner quadrant, say, left-sided. How many of you would consider fast forward? And the second question would be, would you add a boost? I know Santam is running a trial, and Santam, I'll ask Santam to sum it up, but currently, with the current evidence available, left inner quadrant, left-sided, 2.7 centimeter mass, no node, would you use fast forward And how happy would you be to add a boost to it and finish off the whole protocol in 5 days? Jyotirup, yeah.
Yeah, so I mean, I don't think that side is necessarily an issue, but the boost is definitely an issue. So I was fortunate or unfortunate enough to be in the UK during COVID, and they changed over to the fast forward for all patients who were node negative. The only difference with our practice is actually with regard to the boost, because they don't boost everybody, whereas we tend to do that for all comers. So that's something which we have to consider regarding the boost.
So is site not a problem? Santam, is site not a problem? Left?
If you are doing fast forward, I imagine you would adhere to the constraints before doing fast forward, right?
Okay.
If you cannot, you should not be doing fast forward.
So left-sided, what structures would you be worried about? Anish, Suparno?
Heart.
Heart. What in heart? I mean, what in heart means not the structure, of course the structures, and what else? Are you worried about pericarditis more, or are you worried about arrhythmia, or are you worried about, left anterior descending, damage and later coronary events 10 years down the line?
Yeah, coronary events.
All of them you are worried about. Yeah. Are we worried about all of them or
coronary events?
Right. So are we contouring left anterior descending separately and giving constraints to them?
In a routine practice, no.
Shantam, are we doing? All patients, all left-sided breast patients, Jyotirup, Suman, Suparno.
How do you, without contrast? It's
No,
tricky.
there's a way to contour it, of course, there is a way to contour it, but without contrast also. But are we doing it in our routine practice, all left-sided patient? And should we do it? If not, should we start doing it?
First of all, you tell me, are you using DIBH?
Yeah.
Yeah, then you should be doing it.
But I think we should be doing it for all patients.
All
Left anterior descending should be contoured for all patients, like esophagus, lung, and you are doing.
It takes like literally 2 minutes of time.
Yeah, it just takes additional 2 to 3 minutes. And the myth about it is little more difficult to be contoured on a non-contrast scan, but I mean, most of the recommendations now say that you will be doing it on a non-contrast scan.
I think there is good data emerging from the Dutch side that LAD is the OAR. So,
arrhythmias, are we concerned about? Anyone?
Not unless you are treating the AV node for some reason.
Yeah, but there is data. There is data that late arrhythmias after patients who have undergone left-sided breast radiotherapy, and there is data for arrhythmia also being a concern. So, hypot, can you just, I think Sanjay had a word about it. Are you seeing encouraging results with hypot?
Too early to say tumor control results. Our acute toxicity results were quite favorable. So, and we have an interim analysis of the outcome which is due. So, once that is done, we should be able to give you that answer that you are looking for.
Fine. So, I think time is over. So, only last question with the radiation oncologist. In which situations, this is not related to this patient, this is just a question that I wanted to address. In which situations would you avoid radiation post-NSCT in a patient who has undergone mastectomy? Let me be very clear. Patient has undergone mastectomy, before that NSCT, and now you have to make a decision on radiotherapy. Is there a subset of patient in whom you would avoid radiotherapy, or just because the patient has received NSCT, you will do radiation in all these patients? Anybody?
In the interest of time, I will go first. We do for all patients. We do for all patients.
All patients?
Yeah.
If somebody has used NSCT.
So, okay, so two directed questions. PCR and upfront N0 status, NSCT was given for some other reason, maybe large size. Upfront N0 status and pathological complete response. These are the directed questions. In these two, would you still do radiation for all comers, or would you avoid in certain section of patients, or maybe one of these two categories of patients? Prashanjita, yeah.
I think that is the role for extended chemotherapy. So radiotherapy should not be a related indication or a contraindication.
So there is a lot of studies which are going on where can we omit radiotherapy in PCRs and original N0. Having said that, right now there are no recommendations, and right now it is recommended to do radiation for all comers. Rima, are you doing radiation for all comers in this setting?
If not adequately investigated whether node positive at baseline, we would treat all patients with radiation.
Right. So with this we conclude the session. If anyone has any final small comment to make, you are most welcome. Any of the panelists, please. Great. So I think we have had a nice session. Thank you.